I am Dr. Pilar Ortega. I am an emergency medicine physician and a clinician-language proficiency researcher, speaking here in my capacity as a board member and founder of the National Association of Medical Spanish.
Hello, my name is Dr. Karol Hardin, and I'm professor of Spanish at Baylor University, where I teach Hispanic linguistics and also Spanish for health professions. And I'm also a board member of the National Association of Medical Spanish.
Today, we will be discussing language proficiency testing for clinicians, which essentially means testing to determine whether a clinician is able to perform their clinical, patient, or community-facing responsibilities directly in a certain language without a medical interpreter. Many studies describe the value of language concordance, which means speaking the same language between a clinician and their patient. For example, improved outcomes. This means improved health outcomes. And examples of this are understanding instructions for treatment, adherence to treatment because you had better understanding when your doctor spoke the same language as you, better overall outcomes in healthcare, shorter lengths of stay, reduction of unnecessary admissions, and so forth. In addition, there are benefits to rapport with patients and that building of trust, with communities, especially those who, because of linguistic differences with their clinicians and the healthcare system, have previously been marginalized or experienced reduced access to care. And then also efficiency and productivity on the part of the clinician, because if they are able to speak directly with a patient in the same language, it reduces the time that they might need to work within their system to identify a medical interpreter, for example, who can assist them with a particular patient encounter where there is a language discordance. So there are a lot of known benefits of language concordance, but the question is, how do we determine whether that language concordance is there so that the actual communication is effective? And so this is really kind of the backdrop for clinician language proficiency testing. And so I'd like to start by asking you, Karol, clinicians often wonder why they should be tested to determine their proficiency.
Right. Well, current legal requirements don't explicitly require testing for clinicians, but they do for qualified bilingual employees. And so there's a number of reasons why clinicians should test. An obvious one would be to avoid misunderstanding. And there's a well-known account of a patient named Willie Ramirez, whose physician's miscommunication and their inadequate Spanish led to a misdiagnosis and a $71 million lawsuit. And no interpreter was called because the doctor assumed he understood what was being said in Spanish. So clinicians really need to be aware of their language limitations. As you mentioned, Pilar, numerous studies demonstrate how language concordant care results in better outcomes and rapport with patients. And so when doctors are being trained in medicine, we don't settle for, good enough. They're rigorously tested and rigorously trained. And so why would we settle for less when we're talking about the ability to communicate with a patient about those same issues in another language? And in the U.S., if you think about going to your doctor, who would choose to have their doctor's visit with someone who just speaks English at an intermediate level or who just gets by in the language? And the same is true for patients here who speak languages other than English. I would say another point would be that there's levels of complexity and nuance that significantly impact patients' understanding and outcomes, and they have to be communicated effectively no matter what language is spoken. Really, another big question I think that comes up a lot is how can a clinician get tested in a particular language?
Absolutely. And Karol, you raised such important points about the differences in our standard of care for patients depending on their language preference. And I think that's a huge, huge reason why we need to be having this conversation around clinician language proficiency testing. Interestingly, or perhaps unfortunately, we could say Institutional policies on this are really varied. There's essentially no standardization at healthcare institutions as to whether or how they test or offer testing for clinicians who wish to use a language other than English in patient care. So this ranges from no testing at all to asking clinicians solely to self-report their language skills, sometimes in a binary fashion, and we'll talk a little bit more about that later. And other times, there are some tests that are used for clinicians that may or may not be testing the actual skills that clinicians need for patient care. And so there's quite a variety of different things that institutions are doing. And so the first step that I would say to answer your question around how can a clinician get tested, the first thing is to identify what resources are available at your institution or at your center where you work or where you teach, and ask your leadership about it. Maybe investigate what departments might be offering this. Maybe if it's not yours, but there might be a collaboration there that's possible with other departments, depending on what type of institution you are a part of. The reality is a lot of times when clinicians do this, they may find there is a need to advocate for changes in their institutional policy or to clarify what it means to be tested, and then whether they will then be, assuming that they pass whatever testing it is, will they be then allowed to use the language directly with patients? And what are the implications of that? And there's an important difference there in that we're not talking here about testing clinicians to serve as interpreters. We're talking about testing clinicians to see their patients, to do their regular responsibilities in whatever language they are proficient in besides English. Unfortunately, the fact that many institutions currently do not attend to the skills of clinicians with regards to language really ends up meaning that they are devaluing those language skills, even though language is actually the number one thing, and this has been shown in research again and again, language is the number one thing that we as physicians use to take care of patients, whether we're taking the medical history, whether we are doing a physical exam, whether we are talking about treatment recommendations. Everything we do involves language. And so as much as, we talk about all the testing and the fancy technology and all of the things like that we also have at our fingertips, language is such a basic and foundational piece, and yet it is being devalued, particularly for patients with a language preference other than English. And then on the other hand, for a clinician, when you have a policy that is quote unquote unfriendly to speaking and using languages other than English, there is a fear. There is a fear that if you use language skills that have not been officially approved by your institution, that you might be reprimanded. And so I think that is also potentially a barrier to clinicians getting tested or seeking to get tested if they fear that the test is going to not fairly assess their skills. The final point that I would make on this is that hospitals and clinics are quite diverse in the resources they have for many reasons, but one of them is that some places just don't have as many resources as others. And so, if, for example, only remote interpreting is available at a place and there is no language services department, let's say, then there may be limitations to what additional services a hospital or a clinic may have the capacity to provide, and it just may not include, or it may have never been discussed. How could it be that language proficiency testing for clinicians could be somehow incorporated or provided, or what department would be in charge of it, and so forth. So, sometimes these issues can be quite overwhelming to especially small or under-resourced institutions. Yet, as you said, Karol, these issues are actually part of how we can need to comply with federal regulations as to language appropriate care and non-discrimination based on language. So we need to pay attention. We need to find ways to actually make language proficiency testing for clinicians accessible. So to that point, Karol, could you share a bit about what types of clinician language proficiency testing are currently available?
Sure. And I think your point about communication is so important because without communication, there would not be good healthcare. So first of all, I'll talk about overall language proficiency, and medical language proficiency is separate. They're not the same thing. And so some overall proficiency tests for language include the oral proficiency interview, and there's also a computerized format of it that is the American Council on the Teaching of Foreign Languages has. The acronym for the American Council on the Teaching of Foreign Languages is ACTFL, and that would be the main academic body for language professionals, particularly teachers in the United States. And one of the advantages of this, the test is administered by Language Testing International, and it is validated. Of course, there's a cost, and it's a for-profit company. Another issue would be that it's not intended for heritage speakers, so the outcomes would probably not be the same for that. A second testing service would be Diplomatic Language Services, and they use their own tests, and they use the Interagency Language Roundtable. These are a lot of words and acronyms, the ILR scale to assess government employees. And then in Europe, the most commonly used framework is the Common European Framework of Reference for Languages, known as CEFR, and it has proficiency tests in many languages. I would say that for Spanish speakers, the tests are oriented to dialects from Spain, so Latin American varieties may not score as high. And then all of these language tests are proprietary, so they all claim validity, but they don't share their data for research purposes.
Yeah, and I really think that you made some really important points there around heritage speakers, and for those who are listening and may not be familiar with this term, we're talking about individuals who at home were exposed in childhood or while growing up to a language as their home language, but they grew up in a dominant, for example, English speaking, where their formal education was all in English. So, for example, in the United States, many Hispanic Latinos grow up in households where Spanish is a heritage language, but their formal education is in English. And so there is a really interesting, I think this is a group that has a rich cultural knowledge and often linguistic knowledge as well, but their language proficiency may be quite varied and could be, kind of all over the scale. And I think it presents an interesting but very important challenge to address with proficiency testing. And then the piece about language varieties as well. That the fact that we have to value all language varieties equally within a language, and I think that's a really important point about choosing a test that is appropriate, that will fairly value any linguistic variety of the language of your staff. So there are challenges, including these two general proficiency tests and how we might apply them to the clinical context, because as to your point, Karol, it's not the same to test general language proficiency than it is to test that language proficiency as contextualized in a medical context. So I'm going to share a couple of examples of available language proficiency tests specific to the medical context. One of those is the ALTA Clinician Cultural and Linguistic Assessment, known as the CCLA. It is available in a number of languages. The validity data that is published is a pilot study in Spanish, and it has been used across the country. It's a test that was developed by Kaiser Permanente, and I think in terms of the potential, reasons to use this test, it is a phone-based exam. It is accessible to people 24/7, so you can take it because it's a pre-recorded exam. You can take it at any time. There is, of course, a cost to it. It's a for-profit company as well. I think there are some limitations, though. The validity data is limited. That's published, and what's publicly available is a limited amount. So it's a little bit hard to assess some of that. The interaction that you have when you take this exam, it's not a interactive dialogue, so it's a response to recorded cues, but it does focus on that oral communication piece. So I think there are a lot of positives that, and it has been used at a number of hospitals for these reasons. A recent exam that has also been developed, and I've been a part of the development of this one, is called the POLEM, the Physician Oral Language Observation Matrix. And this is a recently developed rating instrument that is used during observed clinical encounters between a clinician and a standardized patient. A standardized patient is an actor that is trained to play the role of a patient. And this is a very standard practice in medical education. So we have begun the development of this test, and all of the testing that has been completed has been done in medical education. So it has been tested so far in Spanish with senior medical students. And some of the pros of how this test has been developed is, one, I think the authenticity of it, because it is a clinical encounter. So it very much aligns with the responsibilities and things you would expect a physician to be able to do in a clinical encounter with a patient. The results that a candidate would receive are fairly holistic in nature, so multiple categories of their performance are reported to them so that they know what they can work on next. So it comes with a kind of a transparency of that rating process, and our team has published a number of papers to document, and it's freely accessible and available in terms of the rating tool itself. I would share that, while the rating tool is available, it does require being trained as a rater to be able to use it reliably. So you can see the results of that reliability testing and the validity study that has been done. And of course, in terms of the cons, this is a live encounter. So even though we've done most of the encounters virtually, there is a high cost to that because you have to have a live person that you're going to be interviewing as part of this exam. And then we have more work to do to make it accessible in languages besides Spanish and among clinicians besides physician learners. So I think it's an exciting area of further development. And then, I'll comment that, as I kind of said earlier, individual hospitals or institutions may have their own tests that they have designed, or they may have their own ways that they've determined they evaluate proficiency. So, it's important to kind of think about, as you are hearing how we have evaluated the pros and cons of different tests that are currently available. Think about how you might apply those questions, as to whether a test is applicable to you when you're examining the tests of your own institutions, if they use their own thing. So that really segues into our next topic here, Karol, which is, what are some aspects that, you as a clinician or a person who's a leader at your institution should consider when you are helping to select or maybe advocating for a certain language proficiency test to incorporate into your clinic or into your hospital system?
Yeah, and that's a good question, because what doctors and administrators are often interested in is the big issue, the cost of the tests and language training courses, and whether or not the institution is paying for that cost or the individual. Another important issue is the time that it takes, and whether individuals will be tested on the clock and the institution will pay for it, or whether it's off the clock. Also, whether training is offered and whether there's retesting available or not, and how long from the initial point of testing. Another issue would be whether or not the institution will provide any on-site language coaching, or whether that has to be obtained externally somehow or online. And then will the institution offer a pay differential? Will there be a pay differential for being bilingual? Since it is extra work, will it be also paid? At the institutional level also, is there training and working with interpreters? Because depending on the level that you test at, you may still need to work with interpreters, and they need to be available. And obviously, clinicians need to know how to work with them in order to appropriately communicate. And then finally, is there a partnership with a clinic or hospital language services in conjunction with the actual language proficiency tests for clinicians?
Yeah, those are excellent points to consider. And in addition, I would add, you have to look for what validity data is out there. Ideally, the validity data will be in some way either published in the literature or publicly available or reported in some fashion. And so you should ask yourself, what is the evidence that this tool is valid for testing the skill that I want to test, which is that language proficiency in a medical context? Keep in mind, not all tools test the same thing. So, I'll say this again, a test for a medical interpreter should not be the test you choose for your clinicians who wish to use a language other than English in direct patient care. They will not or should not be asked to be interpreters. What they're trying to do is be able to use a language directly with their patients, and that is a completely different skill. So that's a word of caution, because I know that there are institutions out there who do use, they don't make a distinction between the tests that they're using. So making sure that the test you're using is actually testing the thing you want to test is a really, really important part of choosing a test. And then context. Context goes along with that, because it may not be the same to develop a test or a scenario. Let's say if you're using something like a tool a rating tool where you're going to observe a clinician performing, you should observe them doing what they're expected normally to do. So that is different depending on the clinician type. A physical therapist does different things than a physician, then a nurse, then a pharmacist, and so forth. And so you need to pay attention to these things, because not every test is necessarily applicable as is. It may be adaptable. It may not be applicable as is to every single clinician type. So depending on, how broad your system is in terms of who should have access to clinician language proficiency testing, you want to think about, is this a test that can be flexible? Is this a test, do I need to think about different solutions depending on my staff roles of people who are bilingual? And then finally, I think the piece about education is really important, because anybody who wants to take a clinician language proficiency test is telling you that they want to take care of this patient population. And that is something that you should celebrate. Just that motivation alone, that they want to do a good job providing language appropriate care, is wonderful. So the last thing we want is for people to take a language proficiency test and then be disappointed and then discouraged from taking care of this patient population if they don't pass. So you have to think about, what are we going to do for those individuals who are motivated to take care of these patients, but maybe are not quite ready at this point to forgo using a medical interpreter when interacting with patients of that language. And so think about that, making sure that whatever proficiency test you choose comes along with, or that you've thought about what kind of educational opportunities you might offer for individuals who really are motivated to take care of these patients and to improve their language skills to provide the best care possible, and to learn to effectively work with interpreters. I think those are things that need to be thought about in any policy that you may create with regards to offering clinician proficiency testing. And we touched on this point a little bit earlier, but I'm curious as to your thoughts, Karol. Not every place is a huge academic center with access to many resources or even, universities nearby where, they may have language instructors and like yourself and people who can help perhaps collaborate on things like this. So what advice do you have for clinicians who work in clinics that are maybe small or perhaps in rural settings where they have access to fewer resources or may even have less linguistic diversity among their staff?
That's a really good question. And so a lot of where I do research is in community clinics, and they don't necessarily have the same resources that large hospital systems have. And so small clinics and community clinics, rural clinics and hospitals really do have limited resources and tend to have fewer bilingual personnel. And importantly, they tend to have less expertise just due to personnel in managing language issues. It may not be as much of a priority, perhaps, not necessarily. They also may not easily be able to afford professional in-person interpreters or even remote language services, particularly if they're very small and have a limited budget. So policies really need to be adapted for the local context, like you mentioned. And just to also add to your point, as you were talking about the testing, I was thinking how for primary care testing, really, it's important to also ask whether there is a mental and behavioral health care component to the testing, since so much of primary care now also does behavioral health and mental health. So those are some of the things that we wanted to share with you today. We have curated a list of key resources, including journal articles and other tools that we referenced during our conversation today. So please pause your screen to take note of the resources you may want to access later. And then I want to just highlight a few of these on our list of references here. One, there's some research articles, such as a report on 10 years of a model language program in residency. There's also a review of outcomes when doctors speak the same language as patients. And then systematic reviews of medical Spanish curricula and resources, including textbooks and online resources and programs for those who are interested in Spanish, where that's the language of interest, but they're certainly applicable to other languages as well.
Absolutely. I think those resources are really important to keep in mind. And, as we close today, I want to share a few kind of key takeaways for each of you to consider. So the first is clinicians really should collaborate with people from diverse disciplines, professions, and perspectives. And this includes linguists, language teachers, interpreters, and community members to gather those perspectives and really take them into account as you're thinking about your policies for clinician language proficiency testing. And then think about the fact that your context may be different than others. And so different contexts may require different solutions for language testing and training. So when you are selecting a solution for clinician language proficiency testing, think about what is the available evidence for that tool or that solution. Secondly, how does it apply to your healthcare or educational setting and to your population, both your patient population and your clinician population? And then finally, don't forget to track your progress, your institution's progress, through data collection that can really help address quality improvement at your own site, and then also advance research in the field. And finally, I'll leave you with a couple of reflection questions for you to consider as a next step in your journey to learning about language equity in healthcare. So after you've listened to this conversation, think about or find out what resources for language proficiency testing are currently available to clinicians at your institution. And it's okay if you don't know, but think about how it is you could find out. And then secondly, list at least 3 individuals, departments, or partner organizations with whom you might be able to collaborate on improving or developing a clinician language proficiency testing plan at your institution. Thank you for joining us.